identifiable conditions or diseases to the list of debilitating conditions currently eligible for licensure under the Medical Cannabis Program. Pursuant to notice, this matter being heard this 7th day of April 2017 at the Reynolds Building in Santa Fe. Time is approximately 10:10 in the morning. I am Dr. Mitchell Simpson. I'm acting as the chair today of the Medical Cannabis Board. DOH Assistant General Counsel Chris Woodward is here. Thank you for running this script to me. He will be advising the department this proceeding. This proceeding is being held in accordance with the Linear and Compassionate Use Act, sections 26-2B-1 through 26-2B-7, and MSA 1978, and regulations at the NMAC Title 7, Chapter 34, Part 2. If members of the audience have not already done so, please sign at the attendance sheet right up in the entrance of this auditorium. We will proceed with the hearing by considering each petition. Applicants have been informed in advance that their petition would be heard today. Petitions have been redacted to protect the confidentiality of the applicant. However, applicants were informed that they may speak directly to the board if they request to do so in advance. In the event that any applicant has made such a request, the board may go into executive session to hear the individual applicant. Only those confidential issues related to the applicant's health status may be discussed in a closed meeting. If we do go into a closed executive session, I will ask that any person who is recording this hearing using any form of recording device, please take the device with them when they leave the room. I don't believe we have any requests for executive session so far. I remind those giving testimony today that this hearing is being recorded. Before you speak, please state for the record your full name and whom you represent. After each witness has testified, I will permit the members of the board to question the witness. Any witness who wishes to submit evidence with their testimony today may do so when they are recognized to testify. At that time, those exhibits will be numbered and entered in the record. The board will begin by accepting statements from petitioner applicants only, which again may take place in a closed executive session, followed by those persons who applied to submit technical evidence relating to the positions presented. The board will accept comments from members of the public later in the meeting after the hearing of the petition. Public comments should concern the petition that's pending or the condition that is being applied for. When we get to the public comment stage, we will ask that you please limit your comments to 2 minutes so that we have time for everyone to offer their comments. Okay. The agenda items will include my initial call to order and introductory comments. It's a fairly long agenda. We will then have a medical cannabis program update, actions of the Secretary of Health for the prior recommendations, then a discussion regarding petition submissions. Based on what we consider to be the stated statutory responsibilities of the Medical Cannabis Board, and with the assistance of legal reviewing the petitions that were submitted, we will be hearing only the petitions that are related to conditions and then having to do with amounts such as the patient-run collectives. The other petitions are felt to require statutory changes, and they're not covered by duties of our board here, the advisory board, and will not be discussed. So we need the medical program cannabis update, please. That's some good news here.
Good morning, everyone. Can you hear me okay? So we have about 35,000 patients at the end of March. Our processing times have improved greatly over the past 6 months. So we've done a lot of internal trainings for our staff since we added so many new staff members to process applications. We've also taken a really close look at just our overall process in the office, and we're going to continue looking at that to see how we can continue to improve. Right now, I would say our staff is doing a tremendous job on patient services side. We're well under the 30-day requirement, and I just want to say that that's for completed applications. When we get an incomplete application, that changes a little. We're trying to work with patients a little closer if there's something missing and are taking a closer look at that. Martin Gonzalez, since the last time, has been named Licensing and Compliance Program Manager. And so we have one vacancy in licensing and compliance. We did interviews for that yesterday. And they're also working on a lot of quality improvement to standardize our inspection forms. We've been out a lot, I would say, over the past 6 months. Some of the feedback we've gotten is we just want a consistent inspection. And so we're working on developing some forms and getting those online and getting those to producers so everyone sort of just knows what we're looking for and what's in the regs. I don't have any other updates. Are there any questions?
Did you want to specifically comment on the turnaround time on a complete new application?
Yeah, it's about 2 business weeks.
So, yeah.
Ms. Monahan?
Thanks. I was just curious, is the volume the same? How many patients would you say per month are you?
We are processing about 1,000 applications per month. No,
Per
no,
week.
per week, sorry.
I was like-
So it's about, in March, we mailed out about 4,000, a little more than 4,000 cards.
Thank you.
Actually, it's 4,482.
Has there been any concern expressed directly to your department by law enforcement about conditions of the medical cannabis program?
No, we've been doing some outreach, and I would defer to Andrew. We've done some educational outreach. We do get calls on the law enforcement line. We try to clarify. We have a law enforcement fact sheet that we updated that we think is a little bit clear. I think our relationship with law enforcement is pretty good. I would say one of my concerns is we still have patients who are turning in applications close to their expiration date, and that is problematic. They need to be turned in 30 days in advance, and it puts us in I don't like to tell law enforcement that a card is expired and that we don't have an application in our office. So we really need patients to account for that mailing time. Just because it was dropped in the mail today doesn't mean we get it today. Certainly when we have holidays, we don't get a grace period for holidays. It's 30 calendar days. But those things just need to be accounted for on the patient end. So the earlier you can get it to us, the better. That way, if there's some missing information, patients will have their cards on time.
Thank you. And can you give us an update on current or in these last 6 months efforts as far as medical outreach and education
Yeah.
throughout the state on medical cannabis issues?
I'm going to let Andrea talk about that because she's been part of some of those presentations. And
Over the last probably 6 months, we have been doing more outreach to medical providers. We've done trainings in Silver City and grants. I believe there was one training done in Las Cruces. We've done multiple trainings for law enforcement. We trained all of Santa Fe Police Department, some of Albuquerque Police Departments, and we have some trainings coming up in small medical offices. So we are actively trying to do some outreach. Our health educator did leave the agency and move out of state because she wanted a better pay or whatever. So she's no longer with us. So myself and Dr. Small have been doing those presentations.
And do you have a current count of how many different healthcare providers have been included in terms of submitting certifications?
I have not run those numbers in a while. We're trying to figure out the best way to do that within our new database. The last time I ran it was probably about 8 months ago, and at that time we had a little over 2,200 different medical providers who had signed off on applications. And that was up from about 3 years ago. I think we were at 983 for a while.
Oh, wow.
And then the second time we ran it, it was at 2,200.
93 to 2,200?
Or 993, sorry, to 2,200.
Okay, thank you.
Mm-hmm. I know somebody else had their hand up out here.
Do you consider 4,000 new patients entering the program every month?
that's not necessarily new patients. It was 4,000 applications, right?
So
So
you're checking a lot of applications then?
no.
Well, there's 1,000 a week.
About 1,000 a
1,000
week.
a month. Oh, renewals.
Well, total applications. So we're processing about 4,000 applications per month, about 1,000 per week.
How
That,
many patients are entering this program?
I don't have a breakdown of that currently. We'll try to get those numbers. Anyone else have questions?
And, yes, and I was wondering, was there any update, you were talking about with Dr. Small, is Dr. Rosenberg still one of the co-medical directors also?
No, Dr. Rosenberg did resign, and so Dr. Small is still with us. We have the position posted. It is a difficult position to recruit for. The position has been posted, I believe, since at least early February, and the applicant pool has been very, very small. So we're using the opportunity with the health educator who left to see if we can reconfigure that position to maybe meet some health education needs and maybe some medical practitioner needs.
Any other questions? Thank you.
Thank you.
Thanks for the, I guess the new office, the new staff has made a tremendous difference.
Absolutely.
That's great. That's great. Next on the agenda is the actions of the Secretary of Health on prior recommendations that were made from the prior meetings in November 4th. That is still forthcoming. And probably, from what I understand, it probably has to do with the fact that there is a bill on the governor's desk that has to do with one of the petitions that was recommended to the Secretary regarding opioid use disorder being added as a qualifying condition. And so the bill is, that would actually cover that, is on there. So presumptively, the governor will make that decision either by signing it or obviously not signing it by noon today. That's the time limit she has. At which point, we're hoping then that the Secretary will forward to us the determinations for that November 4th meeting.
This seems like an unnecessary delay, in our opinion, or certainly in my opinion as the psychiatric member of the,
Yeah, introduce yourself.
I'm Dr. Bill Johnson. I'm the psychiatrist member of the Medical Advisory Board of the Medical Cannabis Program, and I've been a member of this board since it was formed in 2009.
Since birth.
And I just wanted to say that we got the remarks, our report to the Secretary of Health by early November, early December, and so she had a full couple of months before the legislature even met. So to have delayed and citing that as the reason for the delay seems kind of sketchy.
Yes, I'm Dr. Laura Brown, the family medicine member of the Medical Cannabis Advisory Board. Happy to be here. Good morning to everybody. I also find this totally unacceptable, especially because we as the Medical Cannabis Advisory Board have commented on delays in response to our recommendations, delays by Secretary of Health multiple times over the last few years that I've been on this advisory board. And so it's disappointing at best and unacceptable, quite frankly, that we're not getting any response to the hard work that all of us put into coming here at least twice a year.
I'm on board with those comments. We do have, thanks, I forgot to introduce you, Dr. Rachel Goodman is in surgery. Hopefully she will join us shortly, she said. We still have three positions open, right, on this board. We do have a quorum, so that's good. I put out information to the Mexican Medical Society and the Greater Albuquerque Medical Association to pass on the information that we're looking for qualified candidates that have an interest in this board. Nothing quite yet, obviously. Should any of you have physicians who would be appropriate and talk to them about it or know about this, please have them contact us.
And just for everybody, the positions that we have open are for a neurologist, an oncologist, and an infectious disease.
Yes, and Dr. Schwartz had said that she had tried to recruit Dr. Michael Palestine, who was unable to commit to being on this board at this time. So that's the infectious disease position that we're still looking for.
Generally, the major requirement besides interest in this is you have to have an active practice. It can be part-time, but you have to have an active practice.
Active license.
Yeah, active license.
And you have to be board certified, I think.
Yes,
And board
that's
certified.
correct.
Okay. Discussion regarding petition submissions. I'm going to just read through the proposed agenda so that until we get down to the petitions 12 through 22. Per legal counsel's input, petitions numbered 1, 2, 3, 4, and 11 would require statutory changes or are not covered under the duties of the Medical Cannabis Advisory Board and will not be discussed. These are petitions, these are the ones that were listed here. Petitions 6, 8, 10, and 23 concern licensed producers and would require statutory changes. They're also not covered, we feel are not covered under the duties of the Medical Cannabis Advisory Board and will not be discussed. Petitions 12 through 22 we feel are under the duties and responsibilities of the Medical Cannabis Advisory Board, and these will be discussed.
Can I just comment on some of the ones that we will not be discussing? Allowing PPL holders to use manufacturers for conversions of the product into edible forms or tinctures, etc. Seems like a reasonable thing that I, as a certifying practitioner, would see as a reasonable thing to help people get the product in their most sort of friendly form. And then one of the difficulties that we encounter and that will come up probably multiple times during the discussion of the petitions is that cannabis has multiple ingredients in it, and so we have the THC, the CBD, and the other cannabinoids in there, so it's difficult to tease these apart. And it's when back in 2007, when the program was first established, products were typically high in THC, and it was kind of designed to monitor the amount of THC that people are consuming or producing in their cannabis, and that seems to have shifted quite significantly in the past 10 years, with CBD now receiving a great deal of attention. So there was one petition that suggested removing CBD plants from the producer plant count, and it's an interesting dilemma that we encounter, trying to, what is the point of the regulation, or is it to limit THC or just overall consumption? I think it's an open matter that we can discuss in the context of the individual petitions.
Or did you have any comments about the other petitions that we can always add petitions to discuss?
No, not at this time, but I agree with Dr. Johnson about the importance of considering removing the CBD plants from the producer plant count, given the ratios of THC and CBD and how that factors into medical qualifying conditions.
We did at the last meeting and we actually voted in favor of a motion of a proposal to increase the allowable plant counts for the producers. So that's already, we did that at that point, although the question is whether we actually could do that. But I think we just made the suggestion that would be proposed to be considered. So that, as you know, as we mentioned, we don't have the determination from the Secretary of Health yet about that petition.
And petition number 23, which is to provide for an education and research component, I think we've endorsed that in the past as well. I guess we can't formally vote on it, but it certainly seems like, given the the ongoing rapid growth of the program and the comments in many of the petitions about the lack of data collection by the department from the producers or whatever, that would be a helpful thing to add to the program.
And I'd like to add that the idea of developing medical cannabis program educational research components has been addressed in legislation that was introduced in this most recent legislative session that we had. So this is being addressed legislatively. I don't remember the status. I don't think it reached the governor's desk, but I know there's a lot of interest in it legislatively throughout the state.
Okay, we're going to move on to the initial petitions to add the medical conditions. And the first one will be petition 12, which is actually one that we tabled and we're returning to, which is to add autism, and it was previously autism or autism spectrum disorders to the list of approved medical diagnoses.
Dr. Simpson, can you talk about your contacts with the
Yes.
other departments, other states?
So in the petition, there was the previous petition in November, there was a reference to autism having been added as a diagnosis in 2 other states, Delaware and Pennsylvania. So I called both of these boards, and I spoke to one of the people who works in the Delaware board. And the Delaware board approved, this is and you can actually go online and look at it. They have the list of their diagnosis, just like we do. The Department of Health, their program runs underneath in the Department of Health. And this is how it reads, that they were approving it as an accepted medical diagnosis. The diagnosis was autism with self-injurious or aggressive behavior. That's how it reads. So that's in Pennsylvania, I spoke with the people in Pennsylvania. The Pennsylvania program is very new. They've just finished writing the regulations. They're developing the program, which will probably take effect, be active either later this year or next year. So it's really brand new. Theirs just says autism. Okay, that was added. The information I got from Delaware, looking at the petition, because I was able to see some of the information that was submitted, is probably about the same quality. We'll be talking about quality in a little bit of the petition as we received here. I was not able to get anything from Pennsylvania. They didn't have any data that was available for that. But the director said that the major pressure were from constituents of the legislators who were dealing with family or friends with autism. And so that was added right before they finished writing the law.
Dr. Simpson, was self-injurious behavior defined? Is there more specifics?
No.
Because that could be interpreted pretty broadly.
Yeah, I think, yeah. No, that's what it says.
Okay.
And I might remind members on the board as well as the audience that in March of 2010, we heard a petition from Brian Crum regarding severe behavioral disturbances related to autism and also including dementia, TBI, and mental retardation. At that meeting, the board did recommend that this severe behavioral disturbances be added to the list of eligible conditions. That was shot down by the Secretary of Health, and so what is not yet an approved condition. Then sort of going from there and commenting on the petition and kind of the science, we're still hobbled by the lack of good science because we can't research it because it's a Schedule I substance. And autism is a very difficult condition for the individual suffering from it, obviously, and then for the caregivers of that affected person. The application was interesting, and just to review, it was kind of the rationale for the use of cannabis in autism spectrum disorder is that the phytocannabinoids generally promote neurogenesis, provide neuroprotection, function as antioxidants. Their primary role in the central nervous system, or the endocannabinoids, function as neuromodulators. So they might be important in the pathogenesis of autism spectrum disorder, but this is still very speculative, or kind of a big unknown. We don't really know that. The cannabinoids also have anti-inflammatory properties. Within the petition itself, it spoke about anecdotal reports of success that appear to be supported by an abundance of preclinical research, yet later in the same application, there is a statement that preclinical research does not yet provide clear-cut answers. So it's kind of contradictory within the petition in terms of how to interpret the research that is available. And there's quote, there's an unknown impact that treatments have on the developing brain. I am a child and adolescent as well as adult psychiatrist, and that's my main concern, is the unknown effects of there appear to be involvement of the endocannabinoid system in neurogenesis, in development, in fetal development, and in the brains of everybody. So if we tweak that system with external, with bringing in things that attach to these same receptors, are we endangering normal neurodevelopment? Now, a youth with autism spectrum disorder obviously does not have normal neurodevelopment, but even before the interest in the cannabinoids for autism, there's been a great deal of research, and the deficits within the nervous system are still very difficult to characterize. So it's, even as a psychiatrist who studies the journals and sees patients every day, it's, a tough decision as to whether this is a good thing. And then, as I brought up earlier, is THC the good thing? Is CBD the good thing? Is the synergy between these substances the good thing? Nobody really knows. And because there's not been any amassing of data from the clinicians who were watching these conditions, because we're only allowed to recommend rather than prescribe. So it's hard to collect appropriate data. But let's see what else. The petitioner suggested that the first line of action might be to try, in autism, might be to try a particularly high CBD ratio, starting low, going slow, and if no desired effects are achieved, then adding a THC extract and incrementally increasing that based on weight. That seems like a pretty reasonable approach that we use with the prescription pharmaceuticals. And their last statement in the petition, or one of the last statements, was that patients and their physicians should have the right to explore cannabis as a treatment option. And I think basically I agree with that. I have concerns again about age limits, if we should impose an age limit, but I'd like to hear from the other members of the advisory board.
Thank you, Dr. Johnson. I'd like to just add, if we think about the behavioral complications that are seen in patients with autism spectrum disorder, I always think first to harm reduction, and I feel as though many of the current medications that are prescribed to patients with autism spectrum disorder are associated with so many side effects that are much more serious than medical cannabis. I think that harm reduction needs to be factored into any discussion of adding medical cannabis, to adding autism spectrum disorder to the list of medical qualifying conditions. So I just would like us to keep the harm reduction aspects of this front and center.
Thank you. So I want to read a little bit from an article that I supplied here. I pulled this up a few days ago. This is not listed in the petitioners, but it's a recent review from the Journal of Developmental Behavior of Pediatrics from 2015. So that's pretty close. It's called Medical Marijuana: Review of the Science and Implications for Developmental Behavior in Pediatric Practice. These authors from Boston Children's Hospital, Harvard, and
But let it be noted that they get funding from NIDA, which is drug abuse. Use cannabis as a drug of abuse.
right. So the end conclusion is is relatively, I would say, conservative. But I want to read one paragraph here, which I think is what we're sort of talking about, is whether it's cannabidiol or THC or who knows, some of the other 50 or 60 cannabinoids. It says, although far from human application, data from rodents suggests that endocannabinoid system may also be a potential target in developmental and behavioral conditions, though results remain conflicting. I think we know that. Findings from rat models of Fragile X syndrome suggest that blockade of cannabinoid receptors may normalize aberrant hippocampal development and simultaneously correct cognitive deficits, improve seizures, and reduce pain sensitivity. Somewhat conflicting are additional findings that from the same rat model showing that enhancing endocannabinoid signaling may correct abnormal synaptic plasticity in the prefrontal cortex and ventral striatum, with simultaneous improvement in hyperlocomotion and anxiety-related behaviors. So you have a combination of things here. Certainly the major effect of cannabidiol tends to be a partial blockade of the cannabinoid 1 receptors, and if THC is more stimulatory. And certainly we, in the rat models, which are obviously rat models, rats don't have really big cortexes like humans do, but in these models, there's scientific basis for perhaps a combination of both of these. More of the data, I think, tends to lean towards cannabidiol as probably a more effective agent. Their concern, of course, has to do with the unknown issues with developmental issues that Dr. Johnson, exposure to cannabinoids from, say, very early childhood on might affect developmental issues. We don't have that data in, and it's unlikely we're going to get it for a while in humans.
I'm looking at that same article, and there's a further comment that all parties should be fully aware of the long-term hazards of regular cannabis use, but I would expect that many of the members of the audience would say, this is a medicinal substance. There is not a hazard. The cost, the potential side effects that are so heightened in the literature put out by NIDA, etc., are not relevant. Long-term users in medical cannabis programs haven't experienced drastic psychiatric side effects, and they've looked at populations of regular users in Jamaica, places like that, where it's more accepted, and they don't find cognitive or emotional deficits in those people. The profile of and there was a statement in I think one of the petitions, it may not have been this one, that states, the profile of participants in medical marijuana programs in states that have done those are, remarkably normal profiles of people.
Including youth?
Well, I'm sure that most programs have age limits like ours does.
Do we have any comments from the petitioner for this petition? I know that we tabled this last time, and so it's if they want to make comments, this will be the time to do so.
Because it is the first one.
Right. But if not,
And any thoughts on age limits? I mean, basically, as I understand the regs now, to get approved for use in children, the parent has to become a caregiver, and they have to go through a background check. They have to kind of sign off that they want their child to participate in the program. So I think we have a protection there that that not too many people under the age of 18 are going to be participating without consideration from the parent and other concerned individuals.
Do either of you have any sense of how many children have been diagnosed with autism spectrum disorder in New Mexico? I have no idea.
I think it says 1 in 68 nationwide.
I saw that. Right.
depends on the definition, right?
Yeah.
I've seen as low as even lower numbers, but I've seen higher, but that's probably. Do you feel we need to use the Delaware
The behavioral
disturbance, which was similar to what we had proposed?
Again, there was no definition of that, behavioral.
Well, it said
Disturbances or
self-injurious
right.
or aggressive behavior. That's what they described, which is very similar to
the severe behavioral disturbance.
severe behavioral.
Right, but
disturbance.
as defined by the parent or caregiver or the clinician or the teacher or.
They did not say.
Do we have a comment?
I would just like to speak. I have two children with autism. They're 13-year-old boys, 14-year-old boys. And when they were very young, they were self-injurious. As they mature, their outbursts change. And this is all dependent on the person because everyone with autism is different, just like everyone else is different. And so it doesn't express the same way. Now, my boys have extreme generalized anxiety disorder, and they are not so self-injurious anymore. I know parents all around the country and around the world who desperately want cannabis for the treatment of autism because it calms them. It allows them to communicate for the first time sometimes. Their brains are running so much faster than ours all the time, and it allows all of the background noises that we don't hear and see. They have them all the time. It allows all of that to go down to a normal level. It allows them to be calm in their own body. It allows them to stop feeling every single thing that's touching them and to interact in society. It is just a normalizer, and it is so much better than Adderall, which is meth, or Spiritol, which gives boys boobs. I mean, these are horrific drugs that we give very small children, 2, 3 years old. Cannabis is not dangerous like those are, and nobody has a problem. Almost everyone I know medicates their children with those horrific pharmaceuticals, and it would be so much better. So requiring them to be self-injurious before getting it really depends on self-injurious. I mean, as a teenager going out into public and not being able to control an outburst is self-injurious in that they're injuring social communication and relationships. They're not physically harming themselves, but it's still self-injurious. So please consider all of those things.
Right, I mean, early substance use could be considered self-injurious depending on the age, of course.
I'm ready to.
Do I have a
make
motion?
Sure. I would like to recommend that the Medical Cannabis Advisory Board approve autism as defined in DSM-5, autism spectrum disorder as defined in DSM-5 as a qualifying condition for participation in the New Mexico Medical Cannabis Program.
I'd like to second it.
Any further discussion? Our small panel. Any further comments? We have a comment from, a couple comments in back, please.
I feel that if we're going
You go ahead, just go ahead and identify yourself.
Oh, my name is Emily Filomena. I am a community member here. I feel that if we are going to legitimize the use of cannabis and as a medical practice, we need to be able to prescribe it to people without just, suggestive usage, it does, I feel that we do need some regulation of that, because we are willing to prescribe awful drugs to our youth and to our elderly. Like, it's deterring people's health progress and causing them other health problems that I feel cannabis, I've used it for a long time myself, and I have never had a detrimental, interaction with it where I don't feel like I can communicate with others or function or be around people where, painkillers and such have totally changed me, made me feel like a completely different person. I won't touch the synthetic stuff just because I feel it does more harm than good. We need to start looking at cannabis as a legitimate medical practice.
Thank you. We had a comment behind you, somebody behind you?
Board members, my name is Joel Davis. I am I'm on the board of the New Mexico Autism Society. I'm not here in that capacity, just for those who know me from that role. I have a child with autism. Speaking with parents across the state and the country, it's another tool in the toolbox for parents with autism. And one of the things, talking about self-harm and things like that, one of the issues it does, it helps calm the body down. And it's kind of like having overreaching anxiety where you're getting hit with all kinds of sensory issues. And CBD and some of the other compounds in cannabis have shown to help ease some of those issues. So I would ask.
Thank you. Any further comment?
We need a vote on the motion.
Let's vote. We need a vote on motion. All in favor? 3. Motion passes. All right. Well, we did ADHD. We need to also, it's just kind of old business that we're bringing into, we need to, we're going to do ADHD, which we tabled at the last time.
As the psychiatrist and child psychiatrist member of the board, I guess it falls to me to introduce the discussion. I recently reread the petition from the prior meeting, and once again, we're dealing with the petitioner attempting to establish the scientific rationale for the use of cannabis, but the literature, the science really is incomplete and perhaps even inadequate. And then the petitioner comes back and relies on anecdote and says that there's lots of anecdotal reports of improvement in ADHD. As a prescribing psychiatrist, I use a lot of the stimulant medications and non-stimulant medications for ADHD that are, in many cases, remarkably effective, but also carry a side effect burden. So I've seen both sides of this. I would say, based on my anecdotes in my practice, cannabis is not a very effective treatment for ADHD. It's because ADHD first appears in youth, starting really in the elementary school age, the idea of using cannabis to treat the condition means that we would start using it in that early population in elementary school, and because of the concerns about neurogenesis and the developing nervous system, I just feel like we should be conservative about this. But when we're dealing with adults, then I feel like we can, perhaps approve it for use in adults who are making their own decisions, and presumably their neurogenesis and neurodevelopment has been completed. The current definition of adult kind of in the regs is 18. There is some evidence that the nervous system is not completely myelinized, or the tracts are not insulated until really 26, which happens to be the Obamacare number for being on your parents' insurance or whatever. But that's because childhood kind of could be extended to 26 if you're saying that neural development is not complete until then. But I don't know if it's splitting hairs to say we should say it's at age 26 or above, or we should just say, like we did with autism, that because of the age limitations, we would allow adults, anybody defined as an adult in the regulation, to use it or whatever. Any comments?
I would say, I would agree with adding ADHD as a medical qualifying condition for adults. I also have anecdotes from my work at the Santa Fe Recovery Center, where I work with folks with all kinds of substance use disorder, and many of whom who have ADHD and methamphetamine use disorders have been self-medicating with cannabis for years. So again, harm reduction, and it definitely is a safer option for many of them in terms of treating their ADHD than other pharmaceuticals. I do agree with Dr. Johnson that it's probably most appropriate to focus on adults with ADHD at this time. The question
So
is how do we
if we
define it?
pass it as a qualifying condition without an age limit, then potentially we could get parents coming to us and saying, I want it for my kid. And do we want to discourage that by saying we would recommend it only for 18 and above, so that is less likely to, that would be prevented from occurring?
I think we need to think about the risk profile of treatments, ADHD treatments for those under 18 in terms of their efficacy, and comparing the efficacy of the various pharmaceuticals that are prescribed for ADHD versus what we have mostly is anecdotal reports of efficacy with the use of medical cannabis for folks with ADHD in terms of thinking about an age limit.
And scientifically, there's certainly the cannabinoids inhibit the glutamatergic system, so that they're calming and And, they may be modulating, certainly neuromodulating. Since I only deal with adults in my addiction practice. And certainly there's a certain percent of those who have ADHD. Some have self-medicated with stimulants, some just don't, they just try to live with it, learn how to cope with it, and learn their coping skills. And others have been on other medications, prescriptive medications for it. So from my point of view, I have no problems if we make it adults, and if we define that as 18 and above for this program, I have no problem with that. I would.
Again, thinking about harm reduction, many of the patients that I see at Santa Fe Recovery Center who come in with various types of substance use disorders and ADHD have been self-medicating with all kinds of things. And I think that if they're using cannabis to self-medicate, I think it's appropriate for them to be able to access medical cannabis, which could better target, more safely and better target their particular ADHD symptoms than to abuse alcohol or other sorts of substances that are associated with far more harm overall. So I am supportive of this.
Welcome. So we're talking about we're talking about ADHD, which we tabled last meeting. Comments? Do we have any comments from the petitioner or other people about this petition? Yes, you.
My name's Megan, and I just want to ask, if you're sitting here as experts saying that on one hand it's going to help adults, and on one hand you see people in your practice that have suffered substance abuse problems most of their lives and they're now coming to terms that they have ADHD, why wouldn't you allow this medication to youth? Why wouldn't it be allowed to people long before they ever got addicted to anything else as an option? If the parents are saying, I know my child and I go to the doctor and I tell the doctor that I think this will help them, why is it not available then to the youth long before they make it to your substance abuse program and tell you that they've been self-medicating? If these people are already self-medicating, why are we putting an age restriction? Why are we saying, oh, well, you're going to get addicted to alcohol and probably methamphetamines, but God help us, we're not going to let you have access to medical marijuana long before those problems arise in your life. I mean, it just doesn't make any sense, common sense, logically speaking, to say, we know this is a problem, we know it stems from youth, but you know what, we're not sure what's going to happen to a youth's brain, so rather than let them have access with their doctors and their parents to try this long before they try Adderall and liver disease causing other pharmaceuticals, I mean, why block them? Why block them at any point if the parent and the doctor think that this is going to help them, and you think it's going to help them in adulthood? It's not that much brain difference from a 13-year-old who needs this for ADHD, who then goes and finds alcohol and methamphetamines or Adderall or whatever, and then comes to you and says, well, none of that worked, but back when I was 12, I smoked a little pot and that helped me, but nobody gave me access to that, so all I had was all this other crap. And now I've created all these...
Excuse me, ma'am, we do need your name for the record. As a reminder, when you speak, please provide your name. Thank you.
I did when I first stood up. I'm sorry.
Okay, yeah, sorry, I didn't see who.
It's Megan.
Megan, okay, thank you, Megan.
Yes, ma'am. Anyway, I just don't understand why you would limit it to somebody at 18 if you can sit there and say that you know it happens younger and that they're going to go through this process of addiction to all this other shit. Excuse my French, I'm sorry. Why not just make it available now? Why not just say right here, right now, ADHD has seen anecdotally or clinically or whatever some progress. Let's just allow parents the opportunity to use this in the toolbox, just like autism, just like anything else these parents are dealing with these days with all these autoimmune issues and things that are happening to our children. If it's good for one, it's good for all. That's basically what I have to say. I don't think we should limit it to 18-year-olds.
My concerns about neurodevelopment persist, and the FDA in their drug approval process do separate out indications for and have required additional studies for approval of use of certain substances in youth. So, or all substances, it's an additional hoop to jump through to get approval for use of medications in youth. So I think the medical community at large has a shared concern about safety of medications in childhood. We have established medications that have been used safely for 70 years, at least, in terms of ADHD, that are available. And cannabis is not a 100% benign substance. It has its own set of side effects, one of which may be declining IQ according to some studies. And this is controversial, but I think the best study about early onset cannabis use and continued over 25 years showed a modest decline in IQ over that period of time. I'm not wanting to impact people's IQ over time in a negative direction.
But in comparison, you're destroying their livers and lots of other organs with the pharmaceuticals. So if they are 10 points less intelligent on their IQ over 26 years, but I don't have, as a taxpayer, to pay for a liver transplant or severe inpatient rehabilitation for massive drug addiction, it just doesn't add up. What you're saying doesn't add up. Not when it comes to marijuana. Not if you can say on one hand that it is a safer, better substance than pharmaceuticals according to your own body's chemistry, and on the next hand say, but because youth is youth and we're not quite sure, we're going to label it as more of a neurotoxin than say Adderall. I mean, Adderall is one molecule off of methamphetamines, and that's being given to these kids like it's candy.
I think I'm uncomfortable representing medical community perspective on this. I mean, what would be the lower limit? I mean, would parents be involved with giving, recently diagnosed 5-year-old children medical cannabis? I'm not sure the medical community is comfortable with that at this point.
So it's okay for parents to give their kids legal methamphetamines, but it's not okay for them to treat them with an herbal substance, seen as something more positive in the medical community to treat some of these illnesses than the actual pharmaceuticals that are being given out now. I mean, it just seems like you have to take one stance or the other. You can't have it on both sides. You're either for medical cannabis, for the benefits, for the good side of it, with the minor side effects that maybe they lose a couple IQ points, or you're for the pharmaceuticals, you're for the destruction of their bodies, you're for the bigger medical bills, futures, bigger problems down the line. I mean, that's basically what we're here looking at.
Go ahead and introduce yourselves, because we told them you would be coming in a little bit later.
I'm sorry, I'm late. Rachel Goodman, OBGYN. And again, I'm not, I feel the same way, not entirely comfortable representing the medical community. I hear what you're saying, and there are approved medications that have been safe, and they have been used for many years, and I agree there's not without side effects. So perhaps in the future with more studies, it'll be something that opens up. And, personally would be open to seeing the research around that, and hopefully that would be open in the future. I don't think I'm able to say yes or no right now.
We have a motion.
I would move that we approve medical cannabis use, or that we approve ADHD in individuals greater than 18 years of age, that they could access, so that we approve ADHD in individuals greater than 18 years of age be a qualifying condition for participation in the New Mexico Medical Cannabis Program.
Ready, second? Seconded?
I second it.
Any further discussion? Vote?
All in favor?
next petition is anxiety. It's listed as 13 on the agenda, and add anxiety as a condition. Do you have a petitioner that wishes to present the petition?
Andrea, didn't we have a prior discussion of this at some of the other hearings that we've had? And I don't recall it exactly, but I think the Medical Advisory Board has voted to approve this condition in previous years, but the Secretary of Health declined to support our recommendation.
Yes, I did review the records, and I believe it was in 2011. I don't have the exact meeting, that there was a recommendation at that time to add anxiety as an approved condition. However, it was not approved by the Secretary at that time. Basically, the records that I reviewed, the Secretary said that it was due to insufficient material regarding the condition at that time.
So do we have a petitioner that wishes to present this one? Otherwise, we will just go on to discussion. Board discussion.
You know, this is another psychiatric, in the psychiatric realm. Anxiety disorders is a broad sweep. The petitioner did note that that includes panic disorders, social anxiety disorders, selective mutism, various phobias, including agoraphobia. Post-traumatic stress disorder used to be an anxiety disorder. I think it's taken out of anxiety disorders under DSM-5, and then generalized anxiety disorder. Certainly there appears to be some evidence that CBD can be helpful in anxiety. I think there's some evidence that THC can be anxiogenic, meaning that it increases anxiety. So here we're dealing with this sort of splitting apart the substance into its constituent parts, and I don't know if we can make I mean, then it's buyer beware, I guess, if we were to approve it, and or if the Secretary of Health since we had formerly suggested approval, but the Secretary denied it, then it's buyer beware that if the Secretary of Health approved it this time, there is no way that I know of to say, go for the high CBD varieties, folks. I guess the people in the dispensaries who make recommendations about various strains could help the consumer with making this choice, but reading through the petitions about the Education and Research Fund, it's noteworthy that only a small minority of these bud tenders really have medical training behind which they make their recommendations. So again, we're sort of dealing with a murky area, but again, if we're talking about 18 or above, I don't have a major problem going forward to recommend its inclusion.
So in the petition, the research that was presented, and I tried to download as many of these articles. I'm going to make a comment right now about the petitions. Over the years, we've been we really like petitions that reflect the available scientific data. That includes the actual articles, or at least a good abstract that refers to the article. Some of these petitions, all we're getting is just a reference to an article in somebody else's writing without the actual article being able to be cited, as well as sometimes just the title of the article. That's really difficult for us. I spent many hours trying to track down some of these research articles. Okay. I have access through the School of Medicine's library, and many of these articles I couldn't get anything other than an abstract unless I wanted to pay $38 to download the article. It's kind of hard to do if you're downloading 40 or 50 articles, especially in the time frame that we're talking about. So the referred articles in the petition, which are kind of on pages 11, 12, 13, and 14, really all reflect cannabidiol almost exclusively. And I think there's pretty good data there. The cannabidiol, both in animal models and human models, is anxiolytic, meaning it helps reduce anxiety. And if you do things inhibiting the breakdown of, in an animal model, breakdown of cannabinoids, that seems to help with anxiety. Like Dr. Johnson was saying, here now we're going to start splitting off the effects of one cannabinoid versus another, but I think there's adequate data to show that cannabidiol by itself as a solitary agent may be very helpful for, or may be helpful in some people for anxiety disorders, of which there are many, and they're different. And so you might see different responses, because a lot of times in an animal model, you know, how do you know the rat has a generalized anxiety disorder, right? You know, if we have that. So what we're doing is talking about actually more selective use of one of the extracts, which would be cannabidiol by itself, which is available without a cannabis card, because it's primarily hemp oil, and that's available both at dispensaries and actually, you know, over the internet. It also has some other interesting things. So I would actually be less likely to approve this as anxiety disorder, because we don't really have data on THC, but we do have pretty good data on cannabidiol, which is widely available, so that people could try this on their own without having to apply for cannabis card.
Again, I want to point out harm reduction. In the patients that I see, I would so much rather someone use medical cannabis to medicate their anxiety than a benzodiazepine, a Xanibar, Xanax, alprazolam, diazepam, Valium.
Alcohol.
Right, alcohol. The most lethal overdoses that we see in this state and throughout the country involve a benzodiazepine plus an opioid. And unfortunately, people take benzodiazepines as anxiolytics. And so, again, harm reduction. I would much rather see people use medical cannabis than benzodiazepine or alcohol to medicate their anxiety.
Rachel, any further comment?
I'm ready to move that we approve anxiety disorders as a qualifying condition for participation in the New Mexico Medical Cannabis Program.
Any second?
I'll second.
Do we have a second? Further discussion? Any comment in the public? Doesn't appear. We have two hands. Let's start right here.
Yes, my name is Sarah Dole. I understand that you guys really are worried about the fact that people may be dosing with a cannabis that they shouldn't be using for something like anxiety. But you have to remember also that there's a lot of patients that are already in the program that are dealing with anxiety as a secondary thing to PTSD, for example, and they, like everybody else who's in the program, have had to find their particular medicine. So I wouldn't use that as an excuse to not do this, because we all have to find the right medicine for us.
Okay. Somebody right near you? Or, yes.
I would just like to say, my
Your
name
name,
is
please.
Patricia McKay,
Thank you.
and I would just like to say that often anxiety is combined with depression. And I think in some of the strains that offer both CBD and THC, that it's appropriate. It shouldn't be just limited to cannabidiol. I mean, the full cannabinoid expression of each strain. That's all I have to say.
Thank you.
I'd just like to say-
In the back, we have.
Yes, my name's Jason Parker, authored the petition before you. Wanted to point out, as Sarah did, all the qualifying conditions in the program. Anxiety is a component of with symptoms. Same is true for depression as well. And I want to point out too, with the petition process, we had an online petition process. I'd have been able to provide you all those articles too. I can't afford $38 for each of those articles.
I just had a comment. I did work at a dispensary for 2 years with patients, and Larry Lowe, a patient. And the real important thing I find, obviously anecdotally, is that dosage is what is important with anxiety. Cannabis can be really great. If you take too much, it can actually make you anxious, but the right dosage and finding your dosage is the most important thing, I think, with anxiety.
The motion as it stands does not have any reference to THC or CBD ratios.
I'll say one thing. I think that it seems if people, it can be anxiogenic or anxiolytic, and if I would like to trust that if people, no one wants to feel more anxiety, so perhaps they would dose themselves if they felt that they were becoming more anxious, then they wouldn't use it for this reason.
And implicitly, Dr. Goodman is referring to the non-lethality, the sort of that this is a safe substance without known effects, as other audience members have pointed out, without significant systemic side effects.
The other thing I'd like to point out is that if we think about approving any new condition for medical cannabis, we have much more guarantee of a safe product, a safe medication for people. Again, the patients that I work with come to me, many self-medicate with street cannabis, recreational cannabis, and it's often laced with other things, other substances which can be dangerous. And for that reason alone, knowing what you're getting in medical cannabis is super important from my perspective as a clinician.
Including pesticides.
Okay, we have a vote on the motion? Do you have the,
I have the motion, I just need the vote.
All in favor? Opposed? 3-1.
Thank you.
Thank you. Petition 14, depression.
I would move that we approve depression as a qualifying condition for participation in the New Mexico Medical Cannabis Program. To cut short the discussion.
I have actually a point of discussion though. As I reviewed this, are you suggesting all forms of depression? Are we thinking major depressive disorder, bipolar depression? I didn't know if we wanted to think about any specificity.
We have previously discussed this in terms of dysthymia, I believe, and approved it for, did we? And we, bipolar depression was approved with conditions back in 2009. That includes a depressive comment that was not approved by the Secretary of Health. Major depression has come up twice in January of 2009, and we did not recommend it, but then in a petition from September of 2010, we did recommend inclusion, and the Secretary of Health declined our recommendation. There are lots of other treatments of depression, but it seems like cannabis could be added to those possible treatments. We're dealing with adults who the traditional doctor patient relationship, or once upon a time a doctor knew everything and the patient looked to them as an expert who had a superior knowledge base. These days, it seems like we're engaging in more collaborative relationships with our patients and working with them to find the best treatments for their conditions. I think a collaborative relationship with a physician about the use of cannabis as a treatment for depression is probably a good thing. So I'm still in favor of including depression generally.
I second the motion.
Okay, I'm just going to read this, just a comment about, there was and we, as Dr. Johnson put, we've sort of unfortunately recycled this petition, right? Several petitions have done that. Anyhow, there was a really good, really a large, tremendously complex review that was in 2014 about endocannabinoid signaling, and I read that, and it says, you know, there were three things. Endocannabinoids may enhance serotonin transmission, 5-HT. They can enhance 5-HT and norepinephrine signaling, and they may decrease the hyperactivity of the hypothalamic pituitary axis. These are things that sort of so-called standard antidepressants do. That's part of how they work. So that's good that there's a little bit more scientific push, both in humans as well as in animals, studies on this. So we have a motion. There's a second.
Mm-hmm.
Any further comment? Voting? All in favor? 4-0. Okay. Next one is concussions, CTE, and TBI as conditions. Do we have a petitioner who wishes to comment?
Yeah, little petition was here, I want to comment about CBD, what was mentioned previously, being able to access that, not being in the program. Two different forms of legislation were brought forth in legislation this year. The Schedule CBD is Schedule 5 and require a doctor prescription. It died in the legislation, thank God, but they will try and do it again. So CBD may not always be available like that, to be available without, going through the program.
This is a rather broad petition, it seems like. Concussions, traumatic brain injury, and what's the CTE?
Chronic traumatic encephalopathy.
Right.
I had to write it out to remember.
But as Mr. Barker pointed out, there is a government patent on CBD as a neuroprotective agent. At times, the petition seemed to get close to saying football players should pre-medicate with CBD before they get out on the field. But it's non-psychoactive, but if they have a THC component, in the cannabis preparation, I'm not sure I would advise that.
Yeah, the animal data is what mostly is presented here. The rest of it is sort of sports commentary in that, and some of the references were just, which I looked up, were fine. Some from the British Journal of Sports Medicine and Cannabis in Sport. Actually, one of those is just talking about anti-doping perspective. That's what it was talking about. And the other was finding difficulties in dealing with positive urine drug screens in athletes. So I'm not really sure those were really appropriate references. One of the references, number 5, fish fine, long-term behavioral and biochemical effects of delta-9 THC. This is an interesting study, animal study. It was neuroprotective. The doses they're using are about 1,000 to 10 thousandths of what you would deliver. So it's called deliver milligram per kilogram. So it's interesting. That would be an extremely low dose, and that's neuroprotective. If you take the animal, give it to them, give them a brain injury, and then you measure damage. That probably doesn't have any good effect. Like we're talking about, you have to pre-treat before your brain injury. It's kind of hard to do, I guess, maybe unless you're a skater or something. But that shows an extremely small amount might be effective. Several others specifically, once again, talk about cannabidiol as one that may help improve the anti-inflammatory effects centrally after an injury, as well as protecting the blood-brain barrier after injuries, and sort of and other neuroprotective and inflammatory effects. And these are actually quite, I think, well documented, and anybody who wants to study these has shown this, and especially for the brain. There were a couple of references I didn't think that had to do with other parts of the body. Acute lung injury, I'm not sure that should be referenced to in a thing about traumatic brain injury. And the other is that, to me, it's, if we assume a concussion is a traumatic brain injury, which I sort of say it is, then the other issue is chronic traumatic encephalopathy, which is CTE, which is a totally different kind of a degenerative issue that would almost fall into the probably a post-traumatic neurodegenerative disorder. I don't think it's been well characterized exactly what it is, but I think that's sort of a totally different area. I think you're right. This petition seemed to sort of broadly paint what it wanted to cover. So I was hoping if there was a comment from the petitioner about some of the more specific issues.
So just about CTE back, so it's kind of a neurodegenerative disease? Is that what you're saying?
No, I mean, it's just some of the post-traumatic, some of the scanning shows that you get loss, neuron loss and the cognitive issues, and it's progressive. It's kind of a progressive thing, which you see there are other neurodegenerative diseases where we see gradual progressive loss in brain function.
When did traumatic brain injury come up as a petition? Somebody can refresh my memory. I know that we've several times recommended the addition of adding neurodegenerative diseases to medical qualifying condition lists. So CTE might fall under that. And then I can't remember what the history of the traumatic brain injury petition was here. Dr. Johnson, do you remember?
I don't recall, yeah.
And my summary of the petitions that I think Dr. Jennison prepared back when he was the chair doesn't have any specific reference to TBI or the rest.
I did review most of the petitions going back to at least 2011. I don't recall there being TBI as one of the petitions, but I would have to double check to make sure.
There was a petition for TBI in November 2012.
Thank you. How did the commission? How did we approve it, and then the secretary disapprove it, or do you remember, Jessica?
Jessica Klein with the Drug Policy Alliance. I remember that we brought it, and I remember that it was not approved by the secretary, which means that I think you guys did approve it, but I'm sorry I don't have the immediate recall of the votes or the specific decision.
Right, so we recommended it for approval, and the secretary did not agree with our recommendation.
Yes, Ginger Greider. I do know, when you were asking for research and stuff, I do know that Sativex has been approved for the Israeli defense, It's part of their standard kit. Since it has been added to their standard kit, they have seen a 65% reduction in traumatic brain injury when it's administered immediately after they receive their injury, as opposed to prior to them adding it to their kit. So, and I don't know what the CBD ratio is in Sativex. It's only available in Europe, I believe. But along the lines of, CBDs, I found my psychiatrist recommended that I use high CBDs, so I ran out and got high CBDs, and my eyelids swelled up and my lips swelled up. And so, and I went to my bud tender and said, "What's the deal?" And they said, "Well, it's a plant, and because it's been altered to have high CBDs, you're obviously having an allergic reaction to it." And when I went back to just regular, CBD, THC, I didn't have it. So while it may be beneficial for some people, other people are going to potentially have an allergic reaction. I've been to a couple of people since then who have had similar reactions from high CBDs. So it's not the magic cure-all that everybody wants it to be with, just the CBDs, that's all we need. Because for me, I couldn't use medical cannabis anymore if I was only high CBDs.
I definitely see, in reviewing the petition, I think there's great potential for both treatment and palliative aspects of CTE and post-concussive syndrome and TBI. I'm interested in any other comments from Dr. Simpson about this?
No, I don't have any further comments.
Even the petitioner acknowledged that one question is whether repeated dosing would achieve greater protection or conversely exert negative effects on brain health. I don't think we know the answer.
Yeah, I think we have the animal data and maybe some of the human data we don't know. May have, certainly with acute injury, it may be helpful. We have no data on chronic use, and we have no data on that it could be protective in chronic use.
We could decide to table this for further discussion at upcoming hearings, hoping that perhaps some more definitive data emerges.
I know that what I remember, the data that you're talking is coming out of Israel that is in animal models. I think it is acute injury and able to potentially even reverse some of the effects of the acute injury. But I have to review that again. It's been a little while, but I think it is out there and they're working on it. But
Yeah, that's what most of the data that we were able to, at least the ones that I was able to access from is really acute and protecting from acute injury, either prior to, immediately before, or immediately after. So, should we table it?
Yeah, I'd like to table it. I would also like to point out that from my work with patients with TBI, certainly there are self-injurious behaviors that arise from the TBI, for which I think medical cannabis could be palliative, for sure. And in that way, I think this could be very promising.
I think we need to, if we do that, I would like that we sort of split out. We would put TBI and concussions together as one diagnosis and CT as another, because although they're two related, they're not really identical. So okay, so we're gonna table this till our next meeting. Petition 16, diabetes. Any petitioner here to present? Comments? Comments from the board? I guess this is my one medicine. Okay, so the big article, this review article, this really came out in 2013 from the American Journal of Medicine, was talking about, this is a review retrospective. We were looking at, I don't remember how many patients, but a lot of them, and was comparing ones who had at least said they had cannabis use and ones who didn't, which presumptively are the controls. Let me just say that without urine drug screenings on all of the people, these kind of questionnaires are problematic. But Be that as it may, there were quite a lot of people used. And what it showed was some kind of interesting, very interesting things, that the people who were cannabis users had the decreased insulin levels, decreased insulin resistance. These are good things. They had slight decrease in their waist size, which was, of course, unexpected because people think that cannabis leads to the munchies and they would be heavy. Interesting, well, despite those two aspects, that they had decreased insulin and insulin resistance, they didn't have really a change in their overall glucose control. It was not significant. And that's measured by what we call the hemoglobin A1C. So you have diabetes. Now we check that every 3 or 4 months or something, just to really make sure you're going in the right way. There were not really any changes specifically in the lipids as well, which are the triglycerides and the HDL cholesterol. These are the ones that we're always worried about as far as leading to atherosclerosis and things like that. The effect seems to be, if we look at the research, is that, and of course you have to look at the weight and things. This has to do, once again, with the cannabidiol and the way cannabidiol works. The cannabidiol works as a CB1 inhibitor, which we have CB1 inhibitors. One of these is called rimonabant. It's a medication that was developed for treatment of obesity by the company Sanofi. And interestingly, it has very similar effects. In fact,
but it was taken off the market because it promoted suicidal thinking.
Yeah, and it's probably going to come back because I think the post-marketing data doesn't support it as much. But it's interesting because it's this. Not that I want to keep hammering cannabidiol, but the CB1 receptor seems to be interesting, and inhibiting it seems to be the effect, and so that's the higher cannabidiol one that's interesting. Now, it doesn't mean that it doesn't prevent diabetes. Okay, it doesn't prevent diabetes, and it doesn't mean it probably makes your diabetes better. We already have diabetic peripheral neuropathy as one of the, so if you have neuropathic pain, that's okay. But it's interesting that the effect of it is very similar. I think the reason that the cannabinoid works is probably an inhibition of the CB1 receptor, which is not what tetrahydrocannabinol does. That stimulates that receptor. So here again, we're sort of in this dilemma, but it's not a primary drug. Marijuana as a substance or a medication, or however you want to call it, is not specifically used to treat diabetes. But it's possible by inhibiting the CB1 receptor, which cannabidiol tends to do, that it might help with some of the regulation of it. The animal model for diabetes is a rat that they basically kill the beta cells in the pancreas. And so they develop basically what we would call a type 1 diabetes. They don't really make almost any insulin at all. So they develop a lot of problems with their kidneys and their eyes, and they actually develop a peripheral neuropathy. And so these are the rats that are used in these studies. So it's not, some of this is not, I think, directly applicable to the vast majority of people who have diabetes who have type 2 diabetes. And so, because there is a significant difference in those two. Those the type 2 diabetics tend to actually have a little bit more insulin, and they need a little bit more insulin resistance. So there's some, I know this is sort of scientific, but there's some fine differences between these, and using that kind of a rat in cannabinoid studies. The other thing is one of the references, page 17, the number 5, the Redondi one, was a 15-year study of a moderate group. It was from this is published in American Journal of Cardiology, 2006. So I consider that old, but it was an interesting study. And it was looking at people who were regular smokers of marijuana at that point, and they did have increased caloric intake, but not a whole lot, 600 calories a day average. That's not really a whole lot. right, less than a Big Mac. And the concerning thing is that there was a huge increase in the frequency of alcohol use in that group. So the question is, why? I'm not sure. A slight increase of the blood pressure and the triglycerides in this group, and no really change in the lipid profile of the rest of the remaining cholesterols or the overall glucose levels. And then in contradistinction to that one is the one number 6, this one about obesity and cannabis use. And these are from 2 large national studies. This is the NESARC studies in which they've been doing. They've been doing for since the 50s, I think, long time, where they look at all kinds of medical issues, psychiatric issues in the public. And the interesting thing here was that the greater cannabis users seemed to be a little, they weren't quite as obese. Now, they were looking at specific obese populations, show that they weren't quite as obese if they were using cannabis 3 times a week. Does that speak to the diabetes? Not specifically, although diabetes is a risk factor or obesity is a risk factor for diabetes. Other things specifically, once again, relate to blocking cannabinoid 1 receptor with cannabidiol and levodopa, which is not available yet in the United States. So, in my reading of this, it's the effects are interesting. They seem to be pharmaceutical. It's not really. I don't think cannabinoids are effective treatments for diabetes. I think certainly for pain associated with peripheral neuropathy, I think we have good data both and almost any kind of use of that, and that's covered under this. But I don't think, and I think that there may be some interesting issues with cannabidiol, maybe helping a little bit with some of the metabolic, the fine metabolic stuff, but I don't see that there's any evidence that it actually has a significant effect on diabetes control.
I agree that given that painful peripheral neuropathy, sorry about this. Is already a medical qualifying condition, that would cover peripheral neuropathy that's associated with diabetes, of course.
Any comment? Further comment? Or motion? I'll move that we do not add diabetes to the list of diagnoses for any approved for the medical cannabis. Vote?
I have a quick.
Oh, question.
Hi,
for
I'm Shannon Hudavio.
Thank
So
you.
basically, you're saying that, in essence, you're saying that you would approve cannabis as a preventative measure to diabetes, not as a wellness measure.
No, we wouldn't approve. We'd approve it if you have a peripheral neuropathy due to uncontrolled diabetes, which takes quite a few years.
Right.
As an adjunct for pain management, that's approved because that's under painful peripheral neuropathy already on the list. But as a treatment, the primary treatment for diabetes, no. Is it a vote?
It's a no vote, right?
In favor? Yeah, this would be a no vote. In favor of the no vote.
Well, the motion is to not add.
To not
So
add,
those
so
of
it
you
would
that
be-
are in favor of the motion
Yeah, in favor
would
of
be.
the motion. Or is it, we're not adding. Next is for dystonia. Any presenter of the petition wish to comment? Comments from the board?
I did note that spasmodic torticollis cervical dystonia is already a medical qualifying condition. It was not clear to me from the petition that was submitted for dystonia, sort of the range of dystonia that's being petitioned for in this case.
Yeah, so most of the issues most of the diagnoses that are associated with dystonia, or some of the diagnoses associated with dystonia are already on our list. This includes multiple sclerosis, Parkinson's disease, Huntington's chorea, and spasticity associated with a spinal cord injury. But obviously, spasmodic torticollis, which is a different kind of cervical dystonia. So, most of the things that were, we had a lot of case reports in the data that was, on the references that were submitted. We have some research with a mutant hamster strain which gets paroxysmal dyskinesia. And actually there's two from that author. The first one, this guy Richter, R-I-C-H-T-E-R, the first published that he actually felt it was useful, and then the second research he published said that he felt that it was not critically involved in the dystonic in a dystonic syndrome, kind of interesting in the next year. So that just means it's complex. Movement disorders are complex. We know that. We have studies with nabilon, which is a synthetic cannabinoid. It said it was not significantly different. Some pretty old reviews. Most of these have to do. There's a mouse model for multiple sclerosis induced spasticity, and that was also using cannabinoids, but it didn't really specify the mixture of cannabinoids. So I think we already have some diagnoses. I think what we're being asked to do is make this just basically a more broad spectrum for dystonia.
I think there's some evidence that cannabis can reduce muscle tension, muscle contractions, can treat nausea, anxiety, depression, and the pain that goes with dystonia. And it does not seem to exacerbate the process. So I don't have I don't know if there's enough evidence, but I don't have a major objection to approval.
One of these, whoever gave me this, whoever submitted this, actually, number 20, on page 14 here, it's really interesting by Grant Atkinson. It had an interesting, it's called Medical Marijuana Clearing Away the Smoke from the Open Neurology Journal. It had a nice algorithm there for how the doctor should talk to patients about the use of medical marijuana. Very interesting. It was actually quite nice. I'm going to give it to my medical students in my resume. To me, we've already included disease-specific diseases that specifically have dystonia as one of their problematic side effects, and I have no problems with just adding general dystonia. A motion? Do I move it? So moved. I'll move that we add dystonia to the list of approved medical diagnoses for the New Mexico Medical Cannabis Program. Further discussion, public or board? We have a second on that motion? Seconded. A vote? 4-0. Migraines? Petition number 17.
Migraines was approved on a split vote of the Medical Advisory Board in December 11th of 2009, a 5-2 vote, but the Secretary of Health declined to endorse our recommendation and did not approve the condition. So this is revisiting that.
One question I have in thinking about adding migraines as a specific medical qualifying condition, couldn't migraines be considered a subset of chronic pain, which is already a medical qualifying condition?
I can tell you that we do receive a lot of petitions for chronic pain, and the basis of the chronic pain is migraines, and we do approve those.
You said you
Yep.
do receive them, okay.
So can we recommend approval, formal approval of migraines being mentioned as a condition of chronic pain? Do we want to do so?
Yeah, it just says severe chronic pain, so that gets into the definition of chronic. So you have, if it's episodic but chronic, that's by definition sort of what a migraine is. It's episodic pain, it's chronic. And it can be quite severe, and it can be refractory to treatment, or certainly there are lots of side effects to both the medications that are used abortively as well as chronically. So we're already approving, Andrea, so we're already getting those approved. So,
and given sometimes the difficulty in diagnosing migraines as opposed to other types of chronic headaches, do you get a fair number of applications for headaches in general, including migraine, applying under the chronic pain medical qualifying condition?
We have received a few, but most of them will just clearly identify it as migraines.
Okay. The majority are migraines?
Yeah, and how often they're suffering migraines. And so generally those are the ones we get. We've gotten a couple where they've identified it as headaches, and generally if we need, we'll request more records just to identify how long they're going on to ensure that it is chronic and not an occasional.
Does anybody specify menstrual migraines when they apply?
I don't recall that one specifically, no.
I think, if we're already approving under severe chronic pain, and perhaps if we make it a separate entity, it might allow more people that are suffering from migraines to recognize that it could become available to them that might not otherwise be taking advantage of the medicine for themselves. I think we could make it a separate entity already.
I think if we were to do that, it might be a good idea to propose that chronic headaches, including migraine, be included, because certainly other types of headaches are associated with chronic pain. So it's more inclusive and not exclusive by saying only migraines as a type of headache. Many kinds of chronic headaches are associated with chronic pain, not just migraines. I'm thinking of temporal arteritis and other sorts of headache, although it's not really a chronic condition.
we have a comment right
The
here.
only comment I wanted to make in support of migraine being a condition, is I have a family member with diagnosis of migraine and no headaches. It's nausea, but it is still technically migraine. So that's just one comment I want to throw in there. That migraine may be unique from chronic headache.
Yeah, so that's a migraine equivalent. There are a lot of migraine equivalents, although persistent nausea from whatever cause is approved, whether it's, if it's intractable nausea or nausea associated with another disorder or and physiologically there's unquestionably some of the effects of it on the serotonin receptors and blood flow and things in the trigeminal pain, the trigeminal nerve, which for typical migraines is the triggering nerve, or the nerve that least gets triggered. Seems to be there's some good. I think there's some adequate scientific backing up for that one. So. Oh, thank you. Comment? Oh, in the front row first.
Hi, Shannon Littlefield. I was just going to say I liked what Dr. Brown said about making it all inclusive, because there's a lot of underlying issues that cause migraines, TMJ, stress, and other factors that cause migraines that will be excluded if you don't look at it that way. And so I like the all-inclusive approach so that other people can partake and help themselves with cannabis.
So that's suggesting it should be chronic headache, including migraine?
Yes.
Okay.
Yes.
I'd like to make a motion to add chronic headache, including migraine, to the list of medical qualifying conditions for the medical cannabis program.
I'll second that. Vote. Okay, petition 19 is rheumatoid arthritis. This is actually falls under the autoimmune, inflammatory autoimmune mediated arthritis. So that's already covered. We won't need to discuss that petition.
If I may make a quick point on that,
Mhm,
that was
please.
to include all arthritis. Printer had a typo on the printing page, the cover page, and only stated that, but it would basically take rheumatoid arthritis and include all forms of arthritis.
Well, these are inflammatory. It has to be inflammatory. There's different. You have inflammatory, non-inflammatory arthritis. So you have this is to include. So we didn't have to add every type of autoimmune arthritis. Things such as lupus, systemic lupus erythematosus, SLE-associated arthritis, rheumatoid arthritis. Psoriatic arthritis, yeah, I mean the list goes on and on, where we have antibodies that are markers for that type of arthritis, as opposed to, say, degenerative osteoarthritis of the hip or knee that would typically lead to chronic pain, which would then fall under the chronic pain diagnosis. Another comment?
Ginger Grider, I was just, as that classification, I think it would be helpful as far as the education for the health providers, because I myself have rheumatoid arthritis, SCLE, lupus, fibromyalgia, ankylosing spondylitis, which most people don't know about, but is more prevalent than RA, and to have those conditions listed for the medical practitioners in the education, so that when they have a patient come in and they do have some of these rare conditions, then they'll know, oh, okay, well, this is something that I could refer to cannabis. So for an educational purpose, I think it's important that we delineate the autoimmune arthritis condition.
Andrea, if we,
I'm sorry, ma'am. Could you tell me your name again?
Ginger Grider.
Thank you.
if we wanted to add like an explanatory line, hyphenated or in parentheses, such as, would we need to go before the secretary? In other words, definition of what an autoimmune, such as that seen in A, B, C, D, E, and others. Would we need to take that before the secretary?
I'm sorry, I'm not sure I understand your question.
So right, Chris, right, and she's talking about this very good point that Ginger brings up. Okay, that the physician or whoever's doing the certification, right, may not quite understand that whatever they have is an autoimmune mediated arthritis, and there are a lot of them. So the question is whether we put in as a sort of an explanatory parenthetically, such as that seen in rheumatoid arthritis.
I think you could do that. You could do that, and conversely, you could say, but not including such and such. I think you could do it either way.
Okay. Well,
I think that's a really good idea.
we'll do that.
I think also in terms of addressing other non-autoimmune mediated forms of arthritis, those could possibly fall under the chronic pain category as well, just as a reminder.
So just to make sure I'm clear, what you're requesting is that the medical cannabis program modify the application to reflect what conditions would be included in the autoimmune mediated arthritis. Okay.
So we'll do that.
And
Well,
severe chronic pain too? Or?
Yeah.
Well, severe chronic pain's already there.
But
But-
to add such as or not.
I don't think I want to do such as, because some people have these disorders, and the use of the cannabis is not primarily for pain, but for the anti-inflammatory effect. It's their immunoregulatory, and so some people are tolerant to the pain, but it actually helps with mobility, decreases some inflammatory changes, and they're more mobile. The pain it may help with the pain, or may not help with the pain, but there's some other things that it helps with besides just pain, assuming they have pain. That's disabling.
Okay, that is something we can do on the application. However, when I get complaints about it being too long, because we get that
We'll
already.
try- yeah, I'll tell you what, we'll do that between emails between all of us and come up with some of the
Perfect.
diagnosis. I think if we put 4 or 5 or something.
Okay,
we can
that'd be
find
great.
it.
If a doctor doesn't understand what autoimmune disorder is, I mean, why are you doing this for the doctors? They ought to know this already.
Yeah,
It
that's a good
seems
point.
really
Well-
redundant to be adding all those conditions in the list, like Andrea said. Could be 15 long. I mean,
It's really actually for potential medical cannabis patients, right? To
So
know
the
that.
patients don't know what it is.
Right, right. So I think it's more patient education
Yeah.
focused.
It's also, it's such as adding the migraine, which the migraine is actually falling under, Andrew says, falling under chronic pain, but maybe people don't see that because a lot of people would say chronic pain is like, chronic, my back pain every day, I get up with it, it gets
Or
worse.
cancer-related pain.
Or cancer-related.
And I can tell you that we get calls a few times a week from medical providers asking us this exact question: is does that fall under it? And I'm like, oh, I'm not a doctor, and we usually just say, just provide us with records to demonstrate that it would fall under that, and we're fine with that.
So that'll be some work for us offline,
Sure.
so to speak. Okay, good. Sleep disorders, petition number 20.
I found the petitioner's notation that CBN is likely the cannabinoid that is the mostly causing the sedation, somewhat contrary to what I had learned, that it was the CBD, but the petitioner cited that CBD actually activates adenosine receptors, as does caffeine. But I think, that was helpful to me, I think. It's wide, certainly in my practice where I do a bunch of certifications for people with PTSD, relief of insomnia is one of the major cited benefits of their use of medical cannabis. So I would be in favor of approving this petition.
I agree also, Dr. Johnson, as far as insomnia being a primary issue with PTSD clients using medical cannabis.
There are some interesting studies here, sort of like the one where they injected the cannabidiol into the brain of the rat. That was kind of an interesting one. I'm not sure that's how we deliver our cannabinoids to our patients. I'm not, but I'm saying is that, is this appropriate, or is this appropriate for me to read about? I guess it is, sort of, but that's very selective kind of treatment. We have good, we have data. There's actually not a bad data with the Sativex one. This was the one from Mrs. Russo, who seems to do a lot of cannabis research. In 2007, I consider that okay, and did improve sleep with a lot of disorders. A lot of them had chronic pain, rheumatoid arthritis, MS, probably spasticity, probably seemed to subjectively help for maintenance sedating, peripheral neuropathy. The other one, there's another one here. It was interesting, where the effects of combination of THC, where they did multiple THC with CBD at different doses, and that was interesting. I actually did learn that the CBD by itself is alerting, similarly alerting, and that balancing effect there's a threshold effect and then a balancing effect of the combination. A lot of the disorders that are already approved certainly do have sleep disorders, and maybe it's already helping them with their sleep disorders. We don't know. So I think sleep disorders that haven't responded are certainly worth putting in.
I would like to move that we approve the general category sleep disorders as a qualifying condition for participation in the New Mexico Medical Cannabis Program.
Do I have a second? Second. Further discussion? Comment?
Could you just repeat what the exact condition was?
Sleep disorders.
Just sleep disorders? Okay. Sorry, I thought I heard something else. I must have been asleep.
What do you think?
You don't need it.
I think I'm hysterical. That's all I got to say.
Excellent. Petition 21, substance abuse disorder. Oh.
Yeah, I need a vote.
Do I have a vote?
Okay.
4-0, please.
Got it. Thank you.
On to the next petition, substance abuse disorder, petition 21.
This one actually cites a study from here in New Mexico that found a 31% reduction in opioid use after 18 months in cannabis using treatment participants. And Dr. Brown probably has significant practical and clinical experience.
It's anecdotal, but I am seeing a trend among patients in pursuing ongoing use of cannabis, preferably pursuing a medical cannabis card for PTSD, which exists co-occurring with their substance use disorder. Folks are choosing to use medical cannabis to treat their substance use disorder over other forms of medication management for both alcohol and opioid use disorders.
At the last meeting, we approved opioid use disorder, right? So this would expand it. Okay.
So, yeah, once again, oops.
My
Comment?
sources tell me the governor turned down the bill that had opioid dependency, how that was worded.
Okay, so we hopefully will get the secretary to process the November petitions shortly. Yeah, there was this was, once again, I voted no on the previous, and probably good here, but I still like to read all this stuff, and there were a lot of good studies which seem to point to kind of a dialogue again. It's really interesting. There's a large systemic review of the data was published 2015 in Substance Abuse in the journal. It's Canadian, and it's similar. I mean, I think it was saying it seems to be protective for opioids, probably helpful for cocaine, which is and psychostimulators, which clinically I haven't seen it. I don't know how they have managed to track that down, but I haven't really seen any data certainly for methamphetamine stimulation. Methamphetamine use disorder. Hard to say about tobacco and alcohol. Those are probably not available, but there seem to be some data there. Looking at studies and as well as they were reviewing animal studies, that it can be beneficial.
Again, I point out the harm reduction effects of someone choosing to use medical cannabis as a way of reducing their use of their substance of so-called choice. There is good data to support the opioid-sparing effects of medical cannabis in people that are prescribed chronic opioids for a number of conditions. We've heard data here in the past that people can reduce the use of their prescription opioids when they use medical cannabis. And so this is harm reduction in action, and I think it can be more broadly applied to other substances as well.
Any comment from the audience? Oh.
Did you say it might be November then till we hear about the table opioid petition?
I didn't say that.
No, I said now that I suspect.
527 failing and that not being added in through the legislature, we have an idea.
Mm-hmm. No, I don't know.
I actually was wondering if anyone from Medical Cannabis Program staff have heard anything about Secretary's response to our previous recommendations.
I have not.
I have not.
Because the Secretary has not responded to the last recommendations from the last hearing, I asked Chris if there is any kind of a rule at how long she can wait and how long to get back. No. So it can be indefinite or not at all.
In the past, we have actually approved a recommendation that the Secretary of Health respond to our Medical Cannabis Advisory Board recommendations within a set time period. What did we say? Was it 90 days? I can't remember. I'm sorry. But we have made that recommendation, and that wasn't, there was no response to that, right? So.
Remember, we just advised.
That's right.
Sometimes it doesn't go both ways. A comment? Okay. Yes.
All I can tell you is I was on the opiate trail. started to use cannabis and I got off of it. And so they
Okay.
do work, it will work. I mean, it's good medicine, so.
I would just like to say, Larry Love again,
Yeah.
that I think your hard work in making recommendations would get a lot further if we had a physician as the Secretary of Health rather than an attorney.
Mhm.
Right. Right on.
Yeah, I'll second that.
Exactly.
So, we're not, so we have the previous petition, which is, we suggested for opioid use disorder, according to the DSM-5 criteria, which is in the group of petitions that haven't been acted on. We haven't had a response from the Secretary. This is actually obviously a lot more broadly, which would incorporate that. Are we going to specifically require the substance use disorder to be defined by the DMS-5 as we did for opiates?
Again, anecdotally, mostly, when I say this, I've seen the use of medical cannabis most helpful in opioid use disorders, more than other forms of substance use disorders. So perhaps it would be wise to consider tabling this substance use disorder petition for another 6 months to see if further evidence emerges.
Okay, we'll go ahead and table this one.
Excuse me. Hi,
Yes.
Shannon Hudemio again. It's just such an important issue, substance abuse. I mean, it goes along with the dual diagnosis piece. I myself am dual diagnosed. I mean, you got people that have depression, bipolar, they're suffering PTSD, and then suicide rates go up if you couple that with substance abuse. To look at it and table it and just look at it with regards to opioids and take off people that are suffering in these small towns like Socorro, New Mexico with crystal meth. And the good that cannabis can do for people like that in these small towns, and Espanola and all of that, look at people with the cocaine abuse. I mean, to be honest with you, I don't agree with the tabling. I think that we should look at substance abuse as a whole and look at the layers, the many layers, and the dual diagnosis, and look what the effects of cannabis can do on the statistics of suicide rates, and just look at it in a much broader sense. I mean, I think that for me, I wouldn't be sitting here today if it weren't for cannabis and what it's done for my life. My family was scared to death, but at the same rate, it doesn't work for everybody. I mean, sobriety is sobriety. So, I just my suggestion, and I appreciate what you guys are doing, but it's just something that I thought I'd put out there because the dual diagnosis is, as you know, suicide rates go up when people are suffering with both issues.
I hear what you're saying, and I do think that with the votes from today approving the addition of depression and anxiety, which are so often co-occurring with substance use disorders, I think that's a place where we could start for now with a tabled substance use disorder discussion. Just my perspective.
Okay, I think everybody agrees we're going to table that. We'll bring it up. We'll bring it up the next meeting.
Thank you for raising those issues, though. Was it coming back?
Oh, yes, hand here?
I would feel like if we table it today, you talk about environment and risk and harm and stuff, not going forward with these things, and to not have cannabis available for substance abuse users, I think is kind of detrimental to our society. Like, if we're going to approve it for other things, I feel that substance use should be one of them, if it's anecdotally been shown to help.
I'm sorry, ma'am, can I get your name?
Emily.
Thank you.
you for your comments.
Another comment.
Yeah. My name's Megan. And I think if you're trying to address whether or not you're going to give somebody the chance to have medical marijuana over an opiate addiction, if you table it for 6 months, you're going to lose countless lives in the state of New Mexico. People are going to die because they can't have access under this one for substance abuse disorder. If that is what they're dealing with, just today, that's the only issue that they have, and they're an opiate addict, and we wait 6 months to decide whether or not they can have medical marijuana as a qualifying condition, you're putting people's lives in New Mexico in danger. There's at least, let's say, a handful of people who would not die of opiate addiction if they could get a medical marijuana license or their substance.
The thing is, at the previous meeting, we did forward a request that the opiate use disorder be added to the list. So we're pending what the Secretary of Health is going to, and all the other petitions are still pending from the previous meeting in November. So we're still awaiting those decisions now. Petition 22, patient-run collectives.
Looks like patient-run collectives have been approved in other medical marijuana states, including the state of Washington, Colorado, and seems like a good idea to me.
I am especially grateful to see this petition. As you all know, I'm a big advocate for increased access to medical cannabis, especially in the rural, underserved areas of our great state of New Mexico. And so I think this petition would definitely support that move and that effort. So I move to say that we support this petition of patient-run collectives that are also known as licensed personal patient collectives.
I second.
I second it. Further discussion?
Oh, okay, so I'm sorry, Dr. Johnson, you seconded that?
Sure.
Okay, thank you.
Come to vote. That's why I didn't go ahead and ask for public comment. I figured we got a lot to go still.
Dr. Goodman, you're a yes on that one as well? Okay, thank you.
Okay, now on to what's considered adequate supply, which I think part of that is part of the other petition as well. I think it probably should drop down into adequate supply, but we're moving on to that. We have 3 petitions, 579, which involve adequate supply. So 5 is the change in the possession limit to 12 to 16 ounces. Actually,
12 to 16.
yeah, or an ounce per month, right? So that can-
I had a question about this one. I'm looking at Andrea. Wondering how often the medical cannabis program receives medical exemption requests. How many per week, per month, per year, which would be part of this increasing the possession limit, I think.
Right now, we probably get about 3 a week.
3 a week?
Yeah, for somebody requesting an increase.
Okay.
The only time that we've denied them is, for example, I had one doctor that sent in and just referred to the person, I'm just going to make a fake name, Mr. Smith, and we didn't give me the full name, and we had 290 people with that last name. So I did have to send that back and say, I need to know who this is. But typically, if the medical provider didn't provide information related to the medical exception, if they just said they want more, we would have asked for more information. But once we receive that information, we don't deny those.
Okay, thank you.
There appears to be a part of the petition that also suggests allowing cardholders from other states to be able to purchase product here.
Yes.
Reciprocity. I have no objection to reciprocity. But do we need to formally do this if there is that medical exemption process?
I think we need to consider whether the medical exemption process adds an additional barrier to people if they have to call their primary care provider and make an additional appointment with the additional visit with its associated costs. That would be a barrier. If it was already in place in terms of approving this petition, there wouldn't be that barrier.
But that barrier may also be useful to law enforcement who have certain concerns about diversion of product to the recreational market, which is still illegal in this state.
So we're asking to pull those two apart and consider them separately.
I'm not sure. So I would be willing to move that we allow reciprocity, but that we keep thinking about the possession limit. And I forget so what are the other petitions we're going to discuss, and do they cover this as well?
Actually, the other key issue I thought was raised with this petition was the issue of personal production license holders having only one harvest per year, and that being an issue. They often are in possession of a large quantity one time a year at the time of their harvest, which creates challenges for them.
Recommended increases before.
Yeah. I think so.
We did recommend it. We had actually requested increases at the previous meeting. Sure, we were not specific as to the amount, so this petition brings up the specificity of the amount.
Well, it says 12 and then it says 16.
12 to 16. It says 12 ounces or 16. Is the petitioner out there?
Isn't it a range of 12 to 16?
Yeah,
So
no,
maximum
it is
16?
To be increased to the full amount of, increase to 16 in the 3 months is due to mainly, for example, a cancer patient who is treating themselves with Rick Simpson oil. The current 3-month limit right now doesn't allow beneficial use of medical cannabis. Even with the medical exception, adding the additional units to that, to go up to whatever it is, 3.5, still is not enough. Rick Simpson oil for cancer patients who are adequately treat themselves. In a 3-month period, they'd be looking at needing close to 5 grams. It then comes into potency, they need 90 to 95% total THC to actually be effective in the treatment.
I thought that issue that you just raised was focused on another, or was the content of another petition, the removal of the max THC content.
Well, but they all tie in together, just in the aspect of the patients, they need more active supply, they need more available to them. I mean, even during the legislative session, when the bills, medical marijuana changes bill was increasing this adequate supply of this limit as well. But part of the reasoning was it said so patients in the rural areas would have to drive to Albuquerque less frequently. And then that makes more sense right there. We don't need to have patients having to drive 3-4 hours to get their medicine, like that. So increasing this across the board would be a big help, especially when we talk about the collectives.
Absolutely.
Yes.
Up to
3 months. Because that was one of the requirements. This one we have to account. This is a separate issue. It's a separate issue.
Basically, it's looking at, it would be 2.5 ounces every 2 weeks available to the patient. That is 425.243 grams per 3 months.
It's a little bit different, a little bit different number.
That was in the increase advocacy.
Right, which is number, well, no, both of those actually, in petition 5, it also described that as well. About having up to 16 ounces every 3 months. I know some of these overlap. Do you have a comment?
Ginger Brighter, sorry. But this is important to me because of my comorbidity with autoimmune conditions, and over the past 4 years being a medical cannabis patient, we've tried various different forms to treat me to be able to increase the quality of my life. And what we have found is making tincture and for me to consume it all day long. Now, for me to be able to do that, honestly, I'm in violation of federal law and the amounts that I have. We do have a personal production license, so we are able to grow, and we stay within our plant count, but it is very hard sometimes when we have some blight or something else happen, insects will come and destroy it. And so when we harvest, I mean, even I'll have like little panics. I'm like, that's a lot of cannabis, but then we have to put it in a solution or dilution of vegetable glycerin for me to be able to consume. And the amount I have to use each day, around 2 ounces, is the amount I'm allowed to have at all. And we can't produce it every day. And so for me to be able to even come up here without using my walker and participate in this, I mean, it's very difficult. And it does require to put me between a rock and a hard spot. And my husband, my caregiver, between a rock and a hard spot. We want to be compliant with the law, but ultimately I need to have my quality of life. And cannabis is what I choose. Because, I mean, I'm sure you're aware of the drugs for autoimmune, and they're not the same thing because I also have IgG deficiency. I cannot, those have all been removed. So opiates and cannabis are my only, I've been under palliative care for the last 3 years. So, if you would just consider that there are people out there, I don't want to break the law, I don't want to be in violation with anyone, but I do want to treat my condition, and they're way more common than most people know. Thank you.
So we're going to, one
I
comment.
was just going to say I'm in the same boat. This is Sarah Dope again. I want to say that I'm in the same boat as Ginger in that I treat myself using concentrated oils, which I need a large amount of cannabis. And I have to make a choice between whether I am going to have enough medicine for myself or if I'm going to be in compliance with the plant count, so, or the unit count, or the possession count.
Mm-hmm.
So it needs to come up.
So for that, just as a informational question, for those of you who are using tinctures or concentrations, things like that, extracts, is what a 16 ounce per 3 months, is that a target that would be used?
16 ounces in a week.
Mm-hmm. Mm-hmm. Other people?
And remind me, the medical exemption allows you to go up to what number of ounces? I'm sorry, I can't remember.
345.
3.5 per.
345 over 9 months. So
Over
345 grams over 9 months.
9 months?
Or 3 months, sorry.
3 months.
Sorry.
It's less than a pound.
And also consider with adequate supply and what we're talking about with the cannabis plant, only a third of that plant is usable medicine. So you can see a plant looks like a big Christmas tree, only a third of that harvest is usable medicine. And that's where a lot of people they see a bunch of big plants and they think, oh God, that's a whole bunch of medicine. That's not the case at all.
Yeah, that makes sense.
These 3 petitions, are they existing or
They're by the same author, so I think they're consistent.
5 and 7.
Why don't we check now?
Yeah. So I'm going to, I'll make a initial motion that we propose to that increase the adequate supply would be defined as up to 16 ounces per 3 months.
Oh, God.
Second.
Further discussion?
16.
16 ounces per 3 months. We, in the previous petition that we sent to the Secretary of Health, it just said increase. We did not specify anything specifically. We're going to be very specific here, at least in this petition.
So 16 ounces would not cover
Not everybody.
not
obviously.
everybody, but then this medical exemption could does
Partially
that
cover.
partially cover,
Mhm.
not completely. So should we also increase the medical exemption?
That way, for the unique circumstances that require the additional amount, they can have that opportunity.
Well, that way people aren't breaking the law. Like,
So we need to, that's kind of two,
So-
there'll be two different. there'll be two
Right,
different-
so the number of ounces, I know it's right now in grams or units, translated back into ounces, the medical exemption, what is the current ounce medical exemption?
With the medical exception, somebody can have access to 12 ounces over the course of 3 months.
And that, the
90
12
days.
is over what, without the exemption limit, I'm sorry?
The
Is that in ounces?
is 8 ounces, yes.
8 ounces, so then you're basically increased by 50%, so then if you did that, then it would be 50% on top of the 12, so then it would go up to 18. 18.
what if
No, if you use it in that logic, it'd be 24 ounces.
24?
Yeah, because 16 ounces, and and then 8 ounces, half of that would be 8 ounces.
That's
So
right, that's right. So
that's
24
a
ounces.
pound and a half.
Okay,
Now, is that for dispensary buyers or PPLs or both?
good question.
But the ounces, the concentration in a tincture is different than the ounces is going to be in a plant, correct? So how, we can't really, I don't know how to compare those. Really, I mean, what if the medical exemption is a case-by-case basis? Is that fair to,
In terms of the limit,
yeah,
the ounce
give
limit.
the limit?
The ounce limit.
Right now, the way the medical exception works is they get a letter from their medical provider. Their medical provider will tell us how much more that person needs. Sometimes it's been 2 ounces. Most of the time, it has been a request for the full 4 ounce limit to be increased. So right now, we do a kind of a case by case, and it really is up to that patient and their medical provider.
But
I
there's
guess my point is
a
how to-
max of 4 ounces. yeah. You're saying it's a maximum of 4 ounces.
For the increase,
For
yes.
the increase, yeah, the increase of
So maybe I didn't understand your question, Dr. Goodman.
Well, I think my issue with this is that we're still having people that are benefiting from the use, but are still, in essence, not in compliance with the law. And so, how do we bring those two together?
That is the $1 million question. Because the law does say that the Department of Health is required to create a limit of an adequate supply. And that is the amount of product that somebody could use over the course of an uninterrupted supply over the course of 90 days. So we have to create a limit, and the question is, how much it's hard to determine what that limit is for most enrollees.
Does anybody have any other states' ounce limits at the top of their brain to be able to share in terms of considering what is considered an adequate supply in other states? I'm interested, and I should probably research this myself prior to one of these meetings, but
I do have a list back in my office that shows everybody, but it does vary. Like Oregon is 24 ounces. A lot of states have a possession limit, so it's 2 ounces at one time. Right now we have, I believe, the 5th highest rate amount that somebody could have, but it really varies state by state. But a lot of them have gone to, I think we're one of the few that have a use limit over the course of a period of time. But most states have a possession limit of how much you can purchase and be in possession of at one time.
Nevada also has a rule where their limits get reset every 2 weeks instead of every 3 months, and they can have 2.5 ounces every 2 weeks. I don't know if that's something we could do also, because if a patient is purchasing 2 ounces a week, then they're going to run out within a couple of months, and they won't be able to purchase for a long period of time because the dispensaries won't allow them.
And Chris, maybe you can correct me if I'm wrong on this. If, to change that, would we need
It's a statutory.
it's a statutory change?
The statute identifies adequate supply as a 90-day limit, so that's something that's in the statute.
So we have to work with 90-day. Okay.
Or, well, it either says 90 days or 3 months. Say 3 months.
We just have patients having problems not being able to, they're purchasing a lot, they don't grow it, and then they're stuck without medication for quite some time. We're getting in their increases now, but we're, see what's gonna happen then. We're still letting out, not being able to purchase and not have for some time. And they're getting really, their symptomatics are coming, their symptoms are coming back, and they're having to, quit the law.
I've been hearing about this also among my clients using medical cannabis.
So in other words, we can make recommendations for the limits, increasing the limits, but we can't affect the 3-month or 90-day loop period of time. In other words, that would have to be statutory. People have to go to legislature and change it. Okay, well, that's something they can do, but meanwhile, we can request increasing the limits, right?
Mm-hmm.
So,
If we
You
just,
get 16 ounces.
I think I had proposed that we do 16 ounces in the 3-month or 90-day
Is that a motion?
limit. That's a motion. I think I moved it. We were doing discussion after the motion.
Oh, I'm sorry, you are absolutely correct.
Hopefully capture.
We'll
Yeah,
start.
you're right.
We'll start with that. Okay.
Will that allow the exemptions to be increased as well?
That's a second. We're going to do that as a second one. The first one to do this first one. We all agree on.
I'll second.
Seconded. Any further discussion? Voting 4-0. Okay. And then we need to, I think, just talk specifically. We want to give them specific numbers for each of these. Okay, so I think that's it. So for the exemption, increasing the exemption.
So it was by 50%.
Right, commensurate with the previous, yeah. So 24 ounces? I move to add to the medical exemption limit to up to 24 ounces.
Second.
So just to be clear, would that be, the increase would be an additional 24 or a total of 24 ounces?
Total of 20.
Okay, just wanted to make sure. I just had to make sure.
If you could clearly state the motions before the vote, it's a little bit confusing sometimes what
No problem.
you're actually voting on by the time the discussion peters out and, it's
Okay.
written in,
You want to read the first motion?
So we had a motion from Dr. Simpson to increase adequate supply to 6 ounces, which was seconded, 16 ounces, which I can't read my writing sometimes, which was seconded by Dr. Johnson. And then Dr. Brown made an additional one to change the medical exception. So the medical exception would be to increase it to allow up to a maximum of 24 ounces for medical exception over the course of 90 days or 3 months. Is that clear?
16 and 24.
Correct. I need a second.
We need a second on the second motion.
Okay, Dr. Goodman, second. Okay.
Voting 4-0.
Okay. All right.
And on petition number 9, removal of maximum THC content. Of concentrates and other cannabinoids for the concentrates. Present maximum is 70% by weight, right?
Correct. And just as a timekeeper, where it's 12:42. So.
Comment.
And this limit was imposed with the updated rules and regs, right? And I don't think any of us really understood why it was being proposed or.
I remember that we as the Medical Cannabis Advisory Board opposed a limit of 70% officially.
So I would, how about this? I will remove that we remove the 70% maximum content.
I second it.
Further discussion? I don't think there is any. This is, we've done voting 4-0.
Okay, got it. I caught up. All right.
Now we're moving on to public comment. Let me read read here. If I can find it. Okay. Once again, if anybody's not signed the attendance sheet, it's back at the auditorium. We ask that you do so. The attendance sheet is included with the advisory board submission to the secretary. The board will now accept comments from a member of the public. Since we finished hearing our petitions, please, if you wish to come up here and comment, identify yourself and who you represent, if anybody, other than yourself. And limit your comments to 2 minutes. So why don't we have give everybody a chance, and also so we get out here at a reasonable time. I appreciate to date the comments that you've given us. So please come on up. If you so. It's okay. It's okay. Go. And I didn't mention it, but thank you all for muting your phones for this whole period of time. Please come up.
Robert Romero, could you make a recommendation to the secretary on when she'll act on all of these? We hate to be here another year waiting for them to at least say your name.
Robert, I feel your pain. Yes, no, we're hoping. We knew there was going to be a delay because of the bill that was the opiate bill, the cannabis and opiate bill that was being presented. But generally, we've gotten responses within 2 months, 2 to 3 months after we've submitted the petitions to the secretary, which is, I think, plenty of time. There's sort of it's been sliding back, but I will be. If nothing happens in the next week, we'll
one other thing, with the adequate supply going up by that much, I think that the number of plants needs to go up as well to accommodate that. If not, the producers aren't going to be able to supply the medicine.
Okay, Larry.
Hi, I'm Larry Love. I'm a medical cannabis patient, an advocate for patients, an advocate for the program. And delivery systems are very, very important. Patches seem to be a very good way, and for some reason I believe the medical cannabis program has arbitrarily said that DMSO, which I believe is an approved FDA item, which can be bought on Amazon, is not allowed, and therefore it's one of the best ways to make a patch. So I'd like to find out why they arbitrarily did that. And also, in regards to the 70% cap, in order to keep that, they have to adulterate and mix in other items to mix it down. And speaking of that, vaporizing propylene glycol and what is it, MCP? What's it called? It's PG and which is Canada, which is coconut oil, right? Very bad, very bad. And all these pens, a lot of the pens that are here in New Mexico have these items in there, and there's some new evidence saying that smoking propylene glycol and these other things can be very bad for you. So I'd like to do something about that. I think people are getting sick from it. I think patients, please, if you go to your dispensaries or your extract places, ask them for pure cannabis and don't be smoking these other things. Thank you very much.
Okay, we'll have Ginger Grider, is that correct? Sarah Golk will be after Ginger.
First of all, I would like to thank you all for your service and your commitment to the cannabis program. When we were talking earlier about tinctures, it's something that my husband and I have discussed several times, is classifying them as concentrates. Tinctures, oils, butters, those sorts of things are more of a solution or a dilution than they are concentrate, because they're not concentrated. If you start out with 1 pound of cannabis and you mix it, you end up with 1 pound of tincture. It's the same amount. It's not concentrated down. It's not shrunk. It's just a solution or a dilution versus something like shatter or wax, which is a true concentrate. And I would like to see some discussion and further investigation into classifying that so that people that are using tinctures, butters, or oils
are not under the same restrictions as the shatter and the wax and those sorts of things, which are completely different. And thank you for your service.
After Sarah, we'll have David Valdez and Josh McCurdy, and then Robert Romero.
First of all, Mr. Chairman and members of the board, I'd really like to thank you for taking the time to do and taking your job so seriously for our patients and for volunteering for this job. Like Larry, I'm here to talk about the DMSO. It was in the last round of rules, and it was hidden down in a section that nobody paid any attention to because it was a new section being written. And it's section 7.34.4.13, standards for manufacture of cannabis-derived products. And of this number, and then the last part in that section says prohibited products. The use of dimethyl sulfoxide, God, I hope I said that right, also known as DMSO, in the production of cannabis-derived products and the possession of DMSO on the premises of a manufacturer is prohibited. Because this kind of flew in under the radar, they did everything they were supposed to. They put it there, but nobody quite understood at the time that all the transdermal patches that are being used in Washington, Oregon, and California are all made with DMSO, as are nicotine patches, and I think fentanyl patches as well, because it's such a good vehicle for the medicine to get into your body. I would ask that you guys kind of find out why this happened and see if you can get rid of it, because I'm as I've told you before, rheumatoid arthritis and fibromyalgia. These are two of the things that are being studied right now for the use of these patches and are being used very effectively by people in other states. And so this is really, really important to me to be able to have that vehicle. And that's all I have to say today. If you want the information I brought with me, I'll leave it. I'll try it. Thank you.
Thank you.
You guys want this?
Yeah.
Yeah, we do.
I'll send that out to you guys.
Thanks. That'd be great.
Hello, I'm David Valdez from Brief Relief, and I'll be quick. I have been assisting patients for over 7 years now to get on the medical cannabis program, and we had numerous children come into our office with their families and their parents with severe ADHD, autism, and problems that we have to turn away, that we cannot help them. And the most recent one was a 9-year-old who came into the office, and the parents were really, really upset with their boatload of medications, including Vyvanse and Adderall and Valiums and all these other medications. The child had lost 20 pounds in 3 months. He was all bones. She showed me a picture of him, how he was 3 months before, and she was just devastated, didn't know what to do, had all these medications in front of her. And I just want to bring across as to how we could allow children not to be able to access medications for certain illnesses, but yet still be able to let them access it for autism, cancers, epilepsies, and different illnesses like that. They're using the same medications that are destroying them and hurting them. And harm reduction, you keep saying that, I believe the reduction would be a lot better by not allowing them to go through these medications just because their condition is diagnosed differently, but yet they're using the same types of medications and they're not getting any benefits out of it. So that's all I wanted to say. Thank you.
Thank you.
After Josh, we'll have Tricia Monica. Is Tricia still here? Oh, yeah.
Hello, I'd just like to say thank you all. My name is Josh McCurdy. I was the founder of the New Mexico Cannabis Patients Alliance Southern Chapter. I live in Ruidoso, New Mexico, so I'm one of the rural patients. I'm one of the only patients I know that's been denied access from a licensed nonprofit for just giving a complaint saying that medicine wasn't flushed. But I'd just like to thank y'all for the collectives and the increase in medicine and stuff. That really helps where I come from. We're real limited in what we have, quality especially. We depend on certain dispensaries. And if we're not the number one guys in Albuquerque and Santa Fe, they throw everything they can't sell there to us. I just want to let y'all know that. It happens. So I appreciate it. Department of Health, wonderful job of getting the cards turned around. Last year I waited, 60-something days. So I appreciate y'all jumping on that problem and taking care of it. I mean, that's a difference in the program, and you're helping everybody out, and especially with any stress. So thank you.
Thank you.
Believe me, we're happy about it too.
Hi, I'm Tricia Monahan. I think most of you know me. I'm a lawyer, and my focus of practice is medical cannabis law, and I'm also a patient and have been since '09 when I petitioned you guys for nausea and severe anorexia lactica. So thank you so very, very much for everything you do. I mean, from the get-go, really sincerely appreciate you're doing a wonderful job, and it means so very much, and really, really, really thank you. The one thing that I think is under your authority, as you know, is the adequate supply. Well, I think integral to that is available supply. Make sure enough's available. And I hear bigger plant count, but I think the big answer is more producers, more producer. And I just happen to have some previous patient stats here. And in 2015, August 28th, 2015, 16,700 was our patient count. We're more than double that, more than double that. The last time producers were licensed was 2015. We had 23, and 12 more were licensed in 2015 when we had half the patients we have now, and so now we have 25. And it takes them a year to get going, so we need to license more producers. They can serve the communities better. We can license, maybe specify the rural communities if you want. But the more producers, the more competition, the more patients are served, especially community. You know, I just think that's what we really need. It's time now we have to start that ball rolling and get more producers for the patients.
Okay, those are the only folks that requested to speak. A lot of folks put maybe. So my maybes can come on up. Maybe you want to speak?
Hello everyone, my name is Brendan Slevin. I've been a patient since March of 2010 for acute angle glaucoma. I also work at a dispensary in the garden side for the last almost 3 years now. One thing I wanted to hit on is that it's a good thing, I think it's a good thing that we're gonna maybe consider doing the co-ops to help the patients out a little bit more. As well, I think what Ability before me was saying was something about increasing the licenses to increase competition to bring down prices for patients. Because as it stands right now, it's a closed market. And with that being said, these producers are able to charge pretty much whatever they want. So if we increased licenses, we'd be able to help patients out in that manner. As well, I work in the industry like I was saying, so I understand that there are manufacturers' licenses separate than producers' licenses. And what I would like to comment on is I think that would be positive if we would allow a small plant count to the manufacturers as well. This way they're not dependent on producers to provide them with material to make into products, edibles, and concentrates and such. So yeah, that's what I wanted to add. And yeah, I think it's a really good thing that the health department has made it a lot faster for patients to get their licenses renewed. And I'll leave it at that.
Thank you.
Anybody else? Last call.
Question about the patient collectives on the petition, and your recommendation is there guidelines for how those will be run, or will that be later in the draft? A bunch of the guidelines I put in the petition were based off of Washington State, their successful program that they have there. So there is guidelines? Yeah. Okay.
Yeah, those guidelines would have to be written
Yeah, they
into
have to be written,
regulations.
assuming the petition gets.
If it's approved, yeah.
Well, we have one more comment, please. Thank you.
That's okay.
I'll just keep this really quick. Hi, my name is Monique Chavez. I'm the executive director of our newly formed Normal chapter. So I just recently graduated from law school, and I just want to thank you guys for so much of the work you guys do. I know how hard it is to have these other professions and still want to do this too, so thank you guys again. I want to echo what Patricia Monahan said about our producers and the fact that they're really struggling right now. And meeting with many of them, we know that they want to provide and they want to do discount programs, and we have a lot of poverty here in New Mexico, and we have all of these issues, opioid crisis, I mean everything, you name it, we're high on. and everything that's good, we're really at the bottom of the list. So, you know, that's something we really need to think about. But also, I want to emphasize something that's been brought up, I think, numerous times, is a task force. There are so many patients here, so many people, legal people, attorneys, doctors, nurses that want to help. And I know you guys can't do it alone, and I don't know what realm that falls into, if that's the DOH or if that's you guys. But that is something that is desperately needed here. Every state that is legalized has one, and that is so, so important. So thank you guys again. That's all I have to say.
Thank you very much. So, there being no more comment, revising. One more comment. There being one more comment.
Name's Jason Barker. And that was kind of the point with the Medical Cannabis Advisory Board of increasing the membership. We were to increase the membership, just as she had mentioned, add former EMT, add a veteran, bring patients on board to with you guys up there, have a provider represented. That would really, really ease the burden of what you're looking at. It's going to give you a lot more data and a lot more research and science too. Thank you.
Thank you.
All right, seriously, last call.
Seriously. So, thank you. The advisory board would like to thank the witnesses who participated today and those who provided written comments. I would also personally like to thank the board and certainly the DOH staff for their phenomenal support and work, as well as getting that turnaround time
days
down.
till
This has
vacation.
been awesome the last few months. The audience is reminded that recommendations of the advisory board will be submitted to the Secretary of the Department of Health for final determination. Applicants will be notified within 10 days after the Secretary makes the determination. And then I'm proposing that November 3rd at 10 a.m. be the next meeting at this in the Rose building here. There be no further business. I think we're ending for the day. Thanks all.
Thank you. 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 Thank you.